So apologies, I gather John Seville's introduced some of the PBC themes, so I apologise I wasn't here at the beginning. In fact, in the other half of my life, I'm the Dean for Training in NIHR, and we have our ACFs meeting today. And why is that relevant to this? Well, we this year have our first group of people coming into the multiomics and big data strand of the ACF. So for the future of all of this is going to need people, and in NIHR we've developed a new strand to bring people forward to go into the PhD fellowships funded by MRC Wellcome and ourselves. So as well as dabbling in PBC, we're also working really hard on the next generation of people, and many people in the room here have really helped with that. So I think that's going to be critical for the future of this very exciting area. When we launched UK PBC, we gave the patients the floor. I'm a huge advocate of patient and public involvement in research. That the relevance and the importance of it is, it keeps us honest, if you like, as researchers. And we gave the patients group the floor. And I asked them, what are the 3 things you really want us to do? And they gave us 3 answers, the third of which I'll come back to at the end. And the first answer is do something about the name. And this was a disease called primary biliary cirrhosis. Most people with primary biliary cirrhosis don't have cirrhosis, and there is also the association with alcohol, and it really upset the patient. So their first request was to do something about the name, and as you've heard, we did something about the name. So it's now changed. What you used to know as primary biliary cirrhosis is now primary biliary cholangitis. That's now gone through all the professional societies, into the textbooks, and will be in the ICD codes going forward. And I think, to me, that's the best example of patient public involvement I've been involved with. We've really done something which matters. The second thing that they wanted us to do is to snap the world out of a complacency about this disease, the sense that everyone's fine with it, there's no problem here, because they told us story after story after story of young patients who die of this condition or have their lives wrecked. So do something to make this better, and that will really be the rest of the talk. And I'll come back to the third one right at the end. So I'm going to talk about stratified medicine, PBC, finding the key to the door. I would absolutely echo all of the comments that happened before. We too have a big bang coming shortly as all our data sets come together. And the importance of the IMID Bio mega bang, if you like, as I call it, where you bring together the data sets from the different disease areas, I think is potentially enormously important. And we're using common platforms. We too are coming into Transmart. And the data that will come from that, I think, will completely shape our view of these diseases, and I think it's very enlightened of the MRC to fund that connectivity project. So I think it's going to be very, very exciting as we move forward. Now, PBC has a disadvantage compared to other diseases where stratified medicine has been implied. So these are 2 of them are really that it's a rare disease, and it's one that almost nobody's heard of. And so we struggle with that lack of awareness that people have about this disease. And the knock-on effect of that is part of the community that had no interest in PBC was industry. And so in addition to the science of all of this, there is an awareness element that we had to engage in. And so we've had to work very hard to make people aware and to attract industry and researchers into this space. So if I sometimes sound a little bit evangelical, that's because I'm a little bit evangelical. This is the original image from PBC from 1857, Addison and Gull. That is the Thomas Addison, so the same guy who described Addison's disease and hemolytic anemia. So he was the father of autoimmunity, although he didn't know it. And the other author was William Gull, who was a medical student at the time. And for collectors of trivial facts, he's the doctor who is thought to be Jack the Ripper. So PBC has an interesting history of people. What is it? Well, in patient terms, it's a cause of end-stage liver disease. So end-stage liver disease, cirrhosis, liver failure kills people, so that's very important, and it does so with the complications. So we're in a disease state that kills people if you don't manage it properly. There are also real issues about quality of life and symptoms, and that's a really important aspect, that even if your life isn't shortened by the disease, the effect is on the quality of it. But we also see completely asymptomatic low-risk patients. So we have a phenotype that doesn't need treatment or needs minimal treatment. So there is a balance between problems and solving those and also being proportionate. So a model where we gave biologicals to everybody would never work in this disease because the majority of people would be harmed by it, not benefited. In disease terms, this is what we're trying to conquer. This is a rather poorly looking bile duct here at the centre. These are very sick-looking bile duct epithelial cells surrounded by lots of inflammatory cells. So this is the immune response in what is an autoimmune disease, and then you've got some injured hepatocytes. And normally you'd see none of these cells around it, and this would be a very pristine duct. So we have to try and understand why people get this duct change, which drives the process. And this is the sort of current thinking about the disease process, that you start off with an immune injury to the small bile ducts. It's an autoimmune disease at its heart. That was the ragged bile duct I showed you. You then get a state of poor bile flow because of narrowing of the bile duct. That bile accumulates, is itself irritating, and round the cycle you go with cholestasis driving it. Then you lose the bile ducts, become ductopenic, and then you're into the pre-programmed fibrosis and cirrhosis. So you have a sequence of events in the disease, and each of those sequence components has a potential therapeutic target, of which the most important has been bile acid therapeutics in the cholestatic stage, although we'll talk a little bit about immunotherapy. When all else fails, we have transplantation, but don't be fooled. Liver transplantation is associated with lots of morbidity, lots of problems, and PBC patients who have a liver transplant have an 8% chance of going back to work afterwards, 8%. So that is better than dying of the disease, but it is still only a salvage procedure. So we must do much more to prevent people getting to that point. So what opportunity did stratified medicine bring to PBC? It was really simple. It has allowed us to break a 30-year logjam and treat the disease properly. It has been revolutionary in our disease. It has completely cracked this open. The issue that we had was this. This was the first of the bile acid therapies, first-generation treatment, Deoxycholic Acid. It is a hydrophilic bile acid. It is non-irritant, displaces irritant bile acids in the pool, reduces the cycle of cholestasis, and this is the old data on its efficacy. And what you can see here is patients given urso for 2 years versus placebo, and then moving on to urso for everybody. And you can see a small but significant difference. And that's the key. It's a small but significant difference in outcomes. And this led to lots of debate about whether or not this drug was effective, what the issues were with it. And this led to depression in the field. And this was followed up by some trials of agents. And this, in fact, relates to methotrexate and a guy called Burton Coombs from Dallas. And he did the last of the big all-comers trials in PBC. And he wrote an editorial on his own trial. And it's sad to read it, actually. And he said, an all demonstrate efficacy of any medical intervention, an alternate number of patients will need to be recruited. It won't be possible to test more than a few drugs. Regrettably, this is a pessimistic point of view. You weren't kidding. We await a seminal breakthrough which is not yet apparent, i.e., he said, in the field we can never do any more trials and we can't have any advances because there are too many problems. And we wrote a counter-editorial which said the counter-view is what is needed is a re-evaluation of the nature of the impact of disease on patients and a paradigm shift in the approach to trials. And that's essentially what's happened. And if anything, this was the starting point of the whole of this story, that this traditional model of treat everybody with a better disease, because of the issue of people who didn't have high-risk disease, you had this phenomenal problem that you couldn't find a way through it. And it's only when you understand it's a different disease in different people do you make a difference. And this is the thing that really cracks it open. So what you can discover is that there are some people who respond to ursodeoxycholic acid and some people who don't. It's as simple as that. And you can identify those with simple blood biochemical tests, liver function tests, that we do routinely. And there are various different criteria for it. And the truth is it doesn't matter which you look at. The people in blue are people who have near normalization of their biochemistry. Their survival is normal. And the people in red don't, and their survival is very poor indeed. And this was really the first of the UK PBC observations that came out of our MRC StratMed programme. This is real. It really predicts outcome. You can really stratify people after a year of therapy. And there is a really quite significant residual risk in people who don't respond. So this is a starting point for everything that we now do. One of the most important observations we made in all of this, completely flummoxed the field and is now recognised as absolutely correct, is that the risk of not responding to treatment is age dependent. The younger you are, the less likely you are to respond. This is a very aggressive disease in younger patients. And in the older group, who are the commonest group, it's quite benign. And so the patients group was saying, do something about these young patients. This disease is really hurting them. They were right. These are the people. And one of the numbers we use for education is 50. 50 at 50. 50% of patients presenting under the age of 50 will not respond to therapy. That's where the problem is. And that's, of course, why we still transplant people, because all the people we transplant present below the age of 50. So this is the problem. And in many ways, we have a simple biomarker of risk, which is date of birth, actually. And it always rings true. So we are now, this story has unfolded very rapidly and I think effectively. So we had our first generation treatment. And that was ursodeoxycholic acid. And I use the term generation rather than first line for very deliberate reasons, because I think actually we need to revisit all of that. And now we're on to second generation agents, obeticholic acid, which is a farnesoid X receptor agonist, new class of drug. And this is the drug which has now come through into NHS practice. So this is the drug which is now starting to be used in the high-risk patients. Why FXR agonism? It's all about bile acids. As I said, ursodeoxycholic acid is very good at diluting toxic bile acids. That's what it does. It doesn't do anything more specific than that. What OCA and other FXR agonists do is that they have a very specific effect on both bile acid synthesis and bile acid homeostasis. So both directly on the hepatocyte and indirectly via the gut wall through FGF19, you have a suppression of bile acid production and an exclusion of bile acids from the body. So it is a bile acid depleting drug. And if bile acids are driving the process of injury, then you can see how logically these drugs might work. In a sense, an active as opposed to a passive bile acid therapeutic. Also anti-inflammatory gently and anti-fibrotic gently. So potential additional benefits for an inflammatory fibrotic disease. The trial data, this itself was a landmark. This was a disease where there had been no trials for 20 years. The fact that you had phase 2 and then phase 3 trials in high-impact journals was a revolution in our world. And I think for sometimes in disease areas where there has been a constant therapeutic evolution in industry interest, that maybe isn't such a surprising thing. But for us, this is kind of revolutionary. And this takes people who weren't responders to urso and essentially looks at the ability of obeticholic acid to treat those people. And in simple terms, all of these people were non-responders to urso, randomized to 12 months of either placebo with about a 10% conversion rate. Then if you look at the people who were on to obeticholic acid as non-responders, about 40 to 45% of them respond. So we still haven't got everybody, but we have got a significant proportion. So we have now effective therapy for around half of the urso non-responders, particularly the young patients. And it all happens very quickly. So this is alkaline phosphatase. As I say, we use very simple biomarkers for the clinical activity of the disease. Alkaline phosphatase is released by bile duct cells. And what you can see is that with obeticholic acid, the two lower lines, they're just different dosing regimes. You get a very, very rapid reduction in alkaline phosphatase within a couple of weeks. So you are very quickly damping down the irritant effect on the bile ducts. So you get a significant effect and you get a rapid effect. How far away is this from practice? It's in practice, okay? I don't know if John Saville showed you this picture earlier. This was an afterthought, actually, when we went to the FDA around the approval process. We said, wouldn't it be fun to have a photograph outside? And it's the photograph that's gone around the world in the field because it makes a point. So I think the moral for new people into research, take good photographs. They tell a great story. So that's us at the FDA for the approval process for it. The company is a company called Intercept. When I first started working with them, they were a small biotech. They're now a big biotech and are launched. But what's really important is they're a San Diego company, and they do all of their worldwide manufacturing in the northeast of England. So if anybody asks, does research and development lead to manufacturing jobs? Yes, it does. It did here. I'm sure they get good tax breaks and things like that, but there is a culture of collaboration and innovation that has brought manufacturing to the UK. And I'm actually really pleased about that. I think that's a real deliverable from what we do. However, and there is a however with obeticholic acid, it causes itch, and as you saw in my clinical introduction slide, itch is a problem in these patients. So it is by no means a perfect drug. It is a clear step forward, but it has limitations. It also may be toxic in very sick people, which is an issue. And of course, there is the group of people who didn't respond to that. So we're now on to third generation agents, which are fibrate-related drugs, so PPAR alpha, PPAR delta agonists, which again, because they interfere with the bile acid synthesis pathway and may be better tolerated, have some advances. So this is data that came out a few months ago. This is the phase 2 trial of seladelpar, which is the first PPAR alpha delta agonist. And what you're seeing here is in fact normalization of liver biochemistry, not improvement, but normalization. It seems to take it a step forward and has no itch as a side effect. So this perhaps looks like the next iteration of bile acid-directed therapeutics. There were 1 or 2 toxicity issues when you drop the dose. The efficacy isn't quite as dramatic as this, but it seems to be a step forward in terms of symptom tolerability. But all of this looks a bit unambitious, doesn't it? Because what we're doing is essentially iteratively treating people, waiting for them to fail, and we're then instituting more effective therapy. And that's not really the principle of stratified medicine. The principle is understand risk at the beginning and then treat them better. And there is a sting in the tail around the symptoms of this disease, which appear to be of early onset and do not respond to therapy if you don't treat them early. So waiting to fail may eventually allow you to manage the liver disease, but it probably stops you managing the symptoms. So better treatment given earlier, same ethos as in the other diseases, is what we're after. And as I mentioned in one of my questions, we have the advantage of doing liver biopsies on people as part of routine diagnosis. So this is some transcriptomics done on people in whom we have a defined clinical outcome, which was either to be alive and well, responding fully to therapy, which is the low-risk group, or to have not responded to therapy and required a liver transplant. So I think we agree they're high-risk people. And this is their beginning biopsy. This was their biopsy done at the beginning of treatment before they had any treatment, when we then subsequently looked at the outcome. What you can see is there is a clear disease-associated transcriptome. So this is liver transcriptomics, a clear liver transcriptome compared to normal liver tissue, but there is also a distinct phenotype difference between low-risk and high-risk patients. So right from day one, these people are different in the high-risk group. And if you do the characterization of this with pathways, it is around regulation of the innate immune response and so on, T-cell activation, etc., etc., etc. So it is all around the same factors that come out in GWAS analysis for the disease. It's all about immune regulation. So in these very high-risk people, you have a number of very highly relevant immune pathways which are potentially targetable and with a particular transcriptome pattern identifiable in people. And if you want to screen who to screen, then you do it by date of birth. So you're starting to move your way towards an early diagnostic pathway. There is, however, a big but here. And this is the data for ustekinumab, which was used in a flush of excitement in PBC, and it showed, this is the effect on biochemistry, and it showed no benefit whatsoever. So remember, all of these pathways are relevant. I haven't shown you the data on IL-17 and IL-23, all of which are implicated in PBC, as we alluded to before. And IL-12 pathways are hugely important genetically in PBC, and yet this drug didn't work. And this is the only trial in PBC done in the last 10 years which has not been strongly significantly positive. What on earth was going on? Well, the answer is it's all about this, and it's all about sequence and interactivity of different components. That trial looked at people who had already progressed into this stage of the disease. They are therefore people who failed anticholestatic therapy. They're down here, and ustekinumab conceptually was treating this bit up here. So it was the right treatment potentially given at the wrong point in the disease course. And that, in a way, was predicted at the beginning, and it came to pass. It isn't that ustekinumab didn't work, I don't think. It doesn't work when you've fallen off the cliff, if you like, and have failed down at this stage. So hypothetically, if you gave biologicals earlier in PBC, it would have a different outcome. And this is unpublished data, but we did an EME trial of rituximab, so this is the large biological trial done in PBC. We were targeting fatigue in it, which is a whole separate story, but we also looked at biochemistry of patients not selected for having advanced high-risk disease. These are early-stage patients, and you're seeing 90% plus normalization of biochemistry. Not advocating we use rituximab, far from it, but it shows that if you give biologicals right at the beginning of the disease, most people will normalize with them, and I think that's the paradigm for the future. What is happening here? What's going on? Well, it's all about this. It's all about senescence. So we know that where you lose your bile ducts, senescence of the bile duct cells is a key driving factor. But it isn't a passive process, as we'll come to. So if you look at expression of P21 in different groups, you see normal liver, there's a certain level of it. Low-risk PBC, there is no more than in background. High-risk PBC, it's elevated. And by the time you become ultra-high risk at the explant stage, these are the same patients, remember, this is the explant for these people. Originally, you've got very high levels. So senescence of the bile duct cells drives the process of bile duct loss, which drives everything we see. And to put it all together, there is finally an additional loop to it all, and this is something we postulated in 2007, years and years ago, and that was the black bit. The red bits are, if you like, the additional bits to it. We postulated injury-caused cholestasis, proliferation to cope, and eventually you ran out of bile duct cells and become senescent. This was before any of the senescence data came out, so we kind of predicted it. What we hadn't predicted is that this is not a quiet process. These cells don't go silently to their doom. What they do is produce a very pro-inflammatory environment. And it is these senescent bile duct cells that produce CCL20 and IL-23, and they are driving, therefore, the whole of the injury process. So you have a cycle around cholestasis, and you have a super cycle where cholestasis-driven senescence drives the inflammation. And if you only target one of these processes, you are therefore going to have a limited effect. And I now no longer have original thoughts. I just come up with the marketing. So I've christened this the screaming epithelium, that the epithelium is screaming in response to the injury and driving the whole process. Therefore, the fourth generation is a targeted combination therapy in high-risk patients at the beginning of the disease to target both the existing cholestatic process, the highly effective anti-cholestatic agents, and also to put them into an immunological remission. And the observation Ian made about IL-17 in a single dose is precisely the sort of thing that we're talking about. But for us, it's not going to work unless you take out the existing cholestasis. That's where the ustekinumab trial failed. Challenges for developing a therapy program in this area, lots of them, rare nature of the disease, making trials challenging, and this is where the question of mechanism-based trials, the IMID-Bio ethos, if we know a pathway is important, what can we learn from other settings where you target that pathway? The indolent nature of the disease, this makes hard endpoint trials very difficult to do. I don't think I ever want to go back to the FDA and argue about alkaline phosphatase as a trial endpoint. I lost a large point of my life doing that. Acceptability of placebo arms for long-term trials. A lack of validated FDA-accepted surrogate endpoints. This is an issue that comes around again and again and again. And the relative lack of mechanistic data is a limitation, but I think that will come out of the work that we're doing. Increasing activity. This was a disease where no companies were interested. We're now working with 12 in a rare disease. It's saturated. And so the fixed number of patients will ultimately limit. We're going to have to start to make strategic decisions about which interventions to explore. And then there is the whole issue about symptoms. And I think that's the really big challenge to move forward, because I haven't talked about fatigue and the complex symptom set. That is the last bit of this disease to conquer, because fatigue and cognitive impairment happen to all patients, and they do not respond to therapy. And it's largely, we think, because you're treating them too late. And so the paradigm for treatment isn't just about making biochemistry better. It's got to be about making quality of life better. And I guarantee this wasn't fixed, because it seems to be an obligation for all people to talk about stratified medicine to show a Churchill picture. Wasn't coordinated. Mine, I don't think he may have had liver disease, but not autoimmune, I suspect. Mine is now, this is not the end, it is not even the beginning of the end, but it is perhaps the end of the beginning. I think what we've done with all of this is show, in 10 years from Burton Coombs' depressive editorial, that you can actually deliver trials, you can have therapeutic benefit, you can go through an approvals process, you can get NICE approval, and you can implement it into practice. So All of that, and of course that's been transforming to industry because they've seen that you can do it, and they're now starting to look at other rare liver diseases like autoimmune hepatitis, where the same thing can happen. And that's, if you like, the end of the beginning. But there are the challenges left, and the challenges are around symptoms, quality of life, and effective delivery in practice. And the third point that the patients wanted us to address was to end the postcode lottery of this disease, where people 10 miles away from a specialist clinic can die in their 50s without anybody thinking there was anything that needs to be done. And if you don't think that happens, we had a patient from a pretty good district general referred to me, and the letter said, this lady, she's about 50 now, we think it's probably about time that you as the specialist centre had a look at her. We see people all over the country. We thought, would you be happy to have a look at her? She died the day of the outpatient appointment. So there is still a lot to do. So I think this moves from therapies into a situation where the next challenge is how do you get therapies out into practice in a rare disease where knowledge is at a premium in an equitable fashion. So we've made progress. The MRC has been invaluable to all of this. None of this would have happened without them and the patient groups. And I don't think I'm out of a job just yet, but the job becomes a slightly different one. Thank you.